We will now discuss the barriers of the innate immune system. Remember that innate immunity is the first line of defense. It's the immediate reaction. It's the one that's going to hit right from the very beginning. And oftentimes it's going to be the only part of the immune system that you need in order to combat whatever is trying to infect you, be it a virus, be it a bacteria, or fungus, or parasite. It's active at the time of infection. It doesn't need time to get started like the adaptive immune system does. However, in contrast to adaptive immunity, remember that with innate immunity we have no memory. It's all invariant. It responds at the same time, every time. It's clockwork. So for innate immunity, we have two types of components, the non-inflammatory component and the inflammatory component. In this section, we're going to specifically refer to the non-inflammatory or the barrier component, being either a mechanical barrier, a chemical or biochemical barrier, or a microbiological barrier. The inflammatory component, which we'll discuss later, involves the cellular component, phagocytes, NK cells, as well as protein components such as complement and other soluble proteins. But in this section, we're going to focus on barriers. So mechanical barriers include several different types of barrier: intact skin, ciliated epithelium, mucus secretion, the blinking reflex and tears, nasal hair, coughing and sneezing reflex, oxygen tension, urine flow, and temperature. And you can kind of think of this in terms of the pathogen, and maybe it can make a little more sense to you. Now, if you're a pathogen, you want to infect a human. What's the first thing you're going to do? You got to get in. So, if you try to get into a human, the first thing that you're going to hit is skin, right? That's the outermost barrier, and probably the best barrier that your body has, keeping out 99.9% of all infections. What type of environment do you find on the skin? Well, it's salty, it's acidic, it can be oily, not a lot of nutrients there, plus you have all of these bacteria that already live there. Bad news for pathogens. So, unless the skin is breached, it's not getting in through the skin. So, as a pathogen, you think, all right, what's my next step? Let's try to find a way in. Let's find a hole. Where do you find holes? Let's start up top. Ears, nose. Let's start in the nose. If you have the nose, you go through there. Well, there's lysozyme in the nasal secretions. There's ciliated epithelium in the mucous membranes that all try to work to get bacteria or viruses back out. Let's say you make it past the nose. Now you're going down. You have one of two paths to choose from. You can either go down the airway or you can go down the esophagus. If you go down the airway, you have ciliated respiratory epithelium, which again beats against the grain, tries to get stuff up, out. You have the cough reflex, which will do the same, the sneeze reflex, which will do the same. If you happen to make it past all of that, then you get into the lungs. Again, mechanical barriers in the lungs. Now you have things like oxygen tension, which can also prevent the bacteria from spreading or growing or reproducing. So that's kind of a dead end. Let's try the esophagus. If you're going down the esophagus, well, now you encounter the stomach, and once you hit the stomach, you have a chemical barrier, which we'll talk about later. That's acid, bad for the bacteria. Again, we have a pretty good barrier system set up, and we can combat most pathogens that way. So, the times where you might see something going on here, again, you have to think in terms of breaches. The only time you're going to see a problem is if there is a cut in the skin. If there's a cut somewhere in the mucous membrane that can allow a pathogen to pass through. Or, for example, we can think in terms of cystic fibrosis. With cystic fibrosis, the problem is, of course, with the chloride channels, the end result being that you have this thick, sticky mucus. This mucus plugs up the mucociliary elevator, and we know that people with CF have a hard time with what? Upper respiratory tract infections, lower respiratory tract infections. Why? Again, it's because this mechanical barrier is now gone. So, going through the nasal cavity, not a good idea for a pathogen. What about going the other way, through the genitourinary pathway or the GI pathway? Well, the genitourinary pathway, we see things like urine flow, which will prevent, again, the pathogens from moving up. Now, where might we see this in the hospital? Think of a man with benign prostatic hypertrophy. Somebody has benign prostatic hypertrophy, they don't have urine flow like they're supposed to have. And so what happens to them? These are men that get urinary tract infections. You never see men with urinary tract infections. It's always something that's predominantly female, except for in the case of BPH. So there's another example of breakdown of the mechanical barrier. So let's look at this question. 45-year-old man with a history of recurrent sinus infections presents with pneumonia. The medical student suspects Cartaginer syndrome. However, the patient has one child and has levocardia. You suggest that the medical student think of several other possible explanations for this man's pneumonia. Which of the following alter the immune system in a similar manner as Cartaginer syndrome? Choose the best answer. And then we have a whole bunch of answer choices. Now, with this type of question where we have all of these answer choices and then we have G, H, and I, which gives us multiples, what we do is we go through and we just do process of elimination. So first thing you have to know to answer this question is, what is Cartaginer syndrome? If you remember, Cartaginer syndrome is a defect in cilia. Now, does this man have Cartaginer syndrome? The answer would be no. How do you know this? Well, one, because he has a child. People with Cartaginer syndrome, again, because of the ciliary defect, are sterile, unable to have children because of defective sperm. And the other thing you know about this man is that he has levocardia. People with Cartaginer syndrome are dextrocardic, again, because of the inability of the cilia, in this case, to produce the typical gradients during development. So people with Cartaginer syndrome have dextrocardia. This man has levocardia, so you know that he doesn't have Cartaginers. However, the question is asking what would give a similar problem. So again, going back to where the issue is, it's in the ciliary defect. So let's go through these answer choices. A is cystic fibrosis. Would that mimic a ciliary defect? Yes, it would, because again we have this thick mucus that then binds up the cilia and makes it impossible for it to do its job. How about B, benign prostatic hypertrophy? Not so much. C, antacid use. More of a chemical barrier, not quite mechanical, not thinking about ciliary, so again we would eliminate that one as well. How about influenza virus? Well, we know that influenza virus makes proteins that can break down cilia, that can render it dysfunctional. And so the influenza virus might affect a status similar to that which you would see in Cartaginer syndrome. So that's another positive answer. How about E, recent antibiotic use? No real connection there between that and ciliary dysfunction, so we'll rule that one out as well. And then F, smoking. Well, that one makes sense as well. Smoking, we know, damages the cilia and can affect the same type of outcome. So our choices would be A, D, and F, which overall would give us answer G as our correct answer. Let's move on to chemical and biochemical barriers. So these are things like gastric or vaginal pH. We mentioned the acid pH being bad for bacteria. Well, the vaginal pH is the same thing, preventing pathogens from being able to ascend and cause an infection going through the genitourinary tract. Hydrolytic enzymes in saliva, another barrier. Pepsin, defensins, cryptidins, other types of enzymatic proteins that are found in the stomach. Proteolytic enzymes in the small intestine that can break down proteins, can break down DNA, can break down sugars. Those types of things also serve as chemical and biochemical barriers other than being purely digestive. Lysozyme we find in sweat and tears, which is another hydrolytic type of enzyme. And then the sebaceous secretions that we find in the skin that can prevent the bacteria or pathogens from establishing residence, so to speak, on your skin. So all good examples of chemical, biochemical barriers. Another question. 6-year-old girl falls down while playing tag in a nearby field. Bacteroides fragilis is introduced into her scraped knee. Which mechanism would be most effective in quickly dealing with this infection? A, mechanical barriers. B, chemical or enzymatic barriers. C, normal flora. D, humoral response. Or E, T-cell response. The answer is B, chemical or enzymatic barriers. And let's look at how we could approach this problem. We know from the question stem that they want a mechanism that's most effective in quickly dealing. That key word quickly signifies that they're talking about innate response, not adaptive response. So right away you could eliminate both the humoral and the T-cell responses, D and E, and that leaves you with A, B, and C for your choices. Now, since this girl has scraped her knee, you can rule out mechanical barriers. That one's already broken down. Now between B and C, which would be most effective, C doesn't really make sense here. Again, the normal flora is more part of that mechanical barrier, that microbiologic on the surface barrier, but we've already broken that down. So the one that makes the most sense here is chemical or enzymatic barriers, things that you would find in the blood that would help to break down this infection. So microbiological barriers consist of normal bacterial flora on skin and in the GI tract. So what do these things do? Well, they have a crowding out effect. They compete with the pathogens for essential nutrients. And they can also produce inhibitory antibiotic substances. Again, it's all about competition. Your GI tract is teeming with this normal flora that lives there. It's happy there. It already has its residence there. So if a pathogen tries to come in, that normal flora doesn't want it there. It's going to outcompete it for the nutrients that are available, and it's also going to try to keep it out so that it can survive. Now, this kind of symbiotic relationship that it has with the human is very effective, and we can see this in the example of chronic antibiotic use. If you take somebody that's been on antibiotics in the hospital for a long time, they have a great potential for developing what? C. diff diarrhea. Well, how does that happen? Chronic antibiotic use leads to the destruction of the normal flora that's in the gut. Antibiotics do what antibiotics do, so not only do they kill pathogens, but they kill the good bacteria as well. Once that good bacteria is gone, well, now we have this resistant C. diff that can establish residence, produce its toxin, and now you get the C. diff diarrhea, and you have to change antibiotics and try to fight off this C. diff. So there's a good example of a breakdown of microbiological barriers. Another breakdown that you can think of is in terms of the mouth. Again, going back to chronic antibiotic use, a lot of times people can develop oral thrush or oral candidiasis. We can also see this with chronic steroid use for people that, for example, frequently use steroids for asthma. These steroids decrease the immune response. The antibiotics will decrease the microbial normal flora that's in the mouth, and that oral candida can get in, that fungus can get in, establish residency, and start to grow. So you can see candidiasis as well because of a breakdown in this microbiological barrier. Another question. A third-year medical student is sent to a community clinic as part of a rotation. Over the course of one day, the student sees 15 different patients with some sort of infectious disease, but she does not get sick. Which of the following is not one of the immediate defenses against a new airborne pathogen? A. Nasal hair. B. Antibodies in the pharynx. C. Lysozyme in the pharynx. D. Alveolar macrophages. Or E. Complement in the blood. The answer to this question is B. Antibodies in the pharynx. Now, how do you come to this conclusion? Again, going back to the stem, you've got to find that key word. Which of the immediate defenses, or which of the following is not one of the immediate defenses? So immediate defenses, again, you're thinking innate immunity. So the question is basically asking which one of these is not part of innate immunity. The answer then is clear. It's antibodies. That's humoral, that's adaptive immunity. All of the rest of these are innate, and so the answer is B. Another question. Adenosine deaminase deficiency is an autosomally inherited disease in which purine degradation is defective. This leads to the buildup of metabolites that are toxic to both T and B cells. In a patient with this disease, which of the following will still be fully functional? A. Development of specific immunity. B. Activation of lymphocytes. C. Chemical deactivation in the stomach. D. Memory response. Or E. Cytokine activation of immune cells. And the answer here is C. Chemical deactivation in the stomach. Again, going back to the stem, which of these will still be fully functional? We know that this is a deficiency in T and B cells. Thinking on a broader scale, this is a deficiency of adaptive immunity. So if this is a deficiency of adaptive immunity, again, which of these would still be fully functional? You're looking for something innate. And chemical deactivation in the stomach is an innate response. It doesn't require T or B cells, and therefore would not be affected. That concludes our discussion on the barriers of the innate immune system. In the next section, we will cover phagocytes.